Hi, my name is Hannah Levavi, and I'm an assistant professor of medicine in the Division of Hematology and Medical Oncology at the Tisch Cancer Center at Mount Sinai Hospital. And it's my pleasure today to speak with you about the concept of MRD in hematologic cancers. These are my disclosures. The objectives for today are to review the changing definition of MRD, to describe the methods that we use to assess MRD in blood cancers, and also discuss the ways that MRD testing is revolutionizing how we treat and also how we study blood cancers. So first we'll talk about what MRD is. So MRD used to be called minimal residual disease. The more contemporary term, though, is measurable residual disease. And what this means is it's a way for us to determine whether there's any remaining disease after a patient is in remission. So after a patient is given some initial therapy and has a very low level of disease or hopefully no detectable disease using some of our older assessment tools, we now can use this concept of measurable residual disease to evaluate whether there is any tiny little amount of disease left over that we wouldn't have been able to uh, detect using our older methods. And so the way I think of it is in this kind of iceberg analogy where above the water, we have something called morphologic disease, where there's very easily detectable disease using some of the more primitive methods that we've been using for many, many years to evaluate disease burden, such as a bone marrow biopsy or a lymph node biopsy, or even blood tests that very obviously show that there's disease left over. Um, Beneath the surface, though, of the water, we now know that even that using those older methods are not sufficient to identify whether there is still disease left over. And beneath the water, we have this amount of disease that we call measurable residual disease, where even though older methods might not have shown leftover disease, our newer methods do show even very minute amounts of disease that are left over. Beyond that, we do know that there are some people who might not test positive for any disease after they go into a remission, but there probably is some residual disease left over that's non-quantifiable, meaning that we don't have testing methods that would be able to pick up on that disease in this current era in 2025. And beneath that, at some point, we get to a point where there really is no detectable disease left, and people are in a true cure with no disease anywhere in their body that would be detectable using any method that we have. In general, we test for MRD after patients are treated, and this is a way that we deepen our understanding of how deep a remission a patient is in. So when we test for MRD, what we do is we use a number of different methodologies to see whether we can detect any amount of disease. So at the kind of bare minimum level, we use biopsies and use light microscopy, meaning just looking under a microscope to see if there's any detectable disease. In leukemia, for example, and I'll rely a lot on leukemia as a kind of case study for MRD since it is my area of specialty, we call a remission any time in which a patient has less than 5% of their bone marrow or blood with leukemia. So if there's 2% of the bone marrow that still has leukemia, we still call that a remission. But because we're still able to detect that 2% of leukemia cells in their bone marrow when we do that assessment, we call that an MRD positive remission. That's somebody who is in a technical remission by our definitions, but they still have detectable disease using one of these methods. Now we can even go deeper than just a light microscopy evaluation, which has a fairly low sensitivity for disease. And we use a method called flow cytometry, where we can detect even smaller populations of leukemia cell that we wouldn't be able to detect under the microscope using our eyes, even at the maximum magnification. And we call that flow cytometry or flow MRD. So a patient might be in a complete remission with no detectable disease, even using the best microscopes we have, but using flow cytometry, we might detect, let's say, 0.75% leukemia cells. And so that patient would be in a flow MRD positive remission. Oops. Beyond that, we also have other methodologies that deepen our understanding of how deep a patient's remission is. Things like PCR, which is a methodology some people are familiar with from the COVID pandemic because we use this in many, many different testing platforms in medicine. But this is a method where we can identify leukemia or disease-related DNA and then amplify it to assess how much is still there. And PCR can detect even smaller populations of diseased cells than flow cytometry. And then even deeper than that, in some disease states, we can actually use something called next generation sequencing, where we're sequencing disease-specific portions of the DNA and can detect really, really tiny amounts of disease down to one leukemia cell or one diseased myeloma cell out of 1 million cells that are evaluated. So we have very, very sensitive MRD detection methods to determine how deep somebody's remission is. As I mentioned, we use multiple different types of tissues or samples from patients to assess MRD. So sometimes we assess this using just the peripheral blood with a simple phlebotomy, like many patients get with almost every visit to their hematologist oncologist. And other times we use the bone marrow. And depending on the disease and depending on the methodology that we use, sometimes bone marrow is preferred and is more sensitive. Sometimes the peripheral blood is just fine. It also depends on the state of the disease, whether it's a first remission assessment or an assessment after multiple lines of therapy.